Yes, sir, we are live now.
Welcome, friends. Greetings from Acp India Chapter. As you all know that this month we are observing as a Cancer Awareness Month, which has been started on the World Cancer Day on 4th February 2022. We started this series of the cancer talks from 4th of February, and this is probably, and this is actually is the last program in that series of cancer talks. We had a cancer talk on 11th of February in which we discussed the blood cancer. Then we discussed on 18th of February about the tobacco-induced cancer. Then we had a program on for our early career physicians. And now today we are going to discuss GI cancers. I was just looking over the data of the global cancer in which I was trying to find the India figures, and I could see that out of 1.01 million cancer occurring in 1 year in India, the large part, that is 2,27,000, is of the GI cancer. So GI cancer is actually contributing the largest part of those cancers which are occurring in India, and also they are reason for the great mortality. Like 682,000 mortality occurs in India in year, and out of those 1,82,000 belongs to the GI cancer. So GI cancer is definitely the problem which is not so well known to the people. Only cancer specialists may be knowing about that much more, because those patients are usually not visiting to the routine clinical scenario or routine physicians. But we must be aware of that, because then only we can do the early diagnosis of these GI cancers. So as we all know that GI cancers are prominently there, although multiple sites of the GI cancers are there, like most common is the colorectal, and then we can have the stomach cancer, esophagus, gallbladder cancers, pancreas, and liver cancer. But today we shall be taking up the three important cancers. One is the cancer of the pancreas, CA pancreas. Then we shall be talking about the stomach cancer. And then finally, the liver cancer will be talked by Dr. Ashish Kumar himself. Dr. Ashish Kumar is the advisory council member of American College of Physicians, India Chapter. And we are very proud that he has organized and he has coordinated all the speakers, and this program is being visible on the American College of Physicians forum for the first time, in which we can see the top gastroenterologists, top GI cancer specialists are there in our program. So with this program, one apology I would like to place it here, that Dr. Rajesh Upadhyay is not being able to get connected because he is already in the travel. So in his absence, we shall start this program, and this program shall be moderated by Dr. Ashish Kumar. As I already told you that he is our advisory council member. Apart from that, his brief introduction is that he is a professor and senior consultant of the gastroenterology and hepatology, Sir Gangaram Hospital, New Delhi. And another moderator is Dr. Piyush Ranjan. He is senior consultant again at Sir Gangaram Hospital, New Delhi. So both these learned GI cancer specialists or gastroenterologists shall be taking our program move forward with the help of Dr. Govind K. Makharia, who is the chairperson of all the three sessions today. So before I ask Dr. Ashish Kumar to take this program move forward, I will request Ankit, if you have any if you have any arrangement of the inauguration, then you can please connect with that, and then we can go with Ashish with the introduction of the Govind Makharia, and we can start the program with the first speaker. Again, would like to say that Dr. Pramod Garg is joining us a little late. So first talk will be on the stomach cancer, what a physician should know, by Dr. Vikas Singla. So with these words, I will request Ashish to take over and start the program.
Thank you, Dr. Anuj, and Dr. Pramod has already joined. So welcome, Dr. Pramod. So I would like to introduce our chairperson, Dr. Govind Makharia. He's the Secretary General of the Indian Society of the Gastroenterology. The Gastroenterology Society, which has more than 3,500 members from all over India as well as around the globe. He's the Secretary General, and he's the senior professor at All India Institute of Medical Sciences. He has been there since 2002, and he has done a lot of work, especially in celiac diseases, in inflammatory bowel diseases, and he has published lots of guidelines, like in celiac diseases, in diet, global guidelines on diet and gut, and then Indian guidelines on ulcerative colitis, and many other guidelines. So I would like to welcome Dr. Govind Makharia, and I would like him to give him an introduction about the topic for the today's.
Before Ashish, Dr. Govind Makharia take over the session, Ankit wants to have some virtual lamp lighting session. Ankit, you can start with that.
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु.
Thank you. So I would like to invite Dr. Govind to speak a few words about and introduce today's topic.
Thank you so very much, Dr. Maheshwari, for inviting. This is a great initiative on behalf of Acp India Chapter. On behalf of all these speakers, let me welcome you. Thank you, Ashish, for your kind invitation. So coming to cancers, we all know cancers, if you diagnose them early, that they are well treatable. Many of the cancers are curable even. The only question remains how early we diagnose. And that's a key in the cancer management. Therefore, and also want to tell that whatever cancer they are, in early part of their development, there are symptoms, and patient will be totally asymptomatic. Even patient will not know that they have harboring cancer in their body, or some cells are aberrant. Even physician will not know, because early part of cancer symptoms are non-specific. They overlap with many conditions, especially functional GI conditions, especially if we're talking about GI cancers. So the patient will have mild discomfort, mild pain abdomen, and they go to a doctor and you see, okay, they will dyspnea or something, and we wait till more classical symptoms appear. And when the more classical symptoms appear, we investigate and find the cancer is already far advanced. Is already at the stage when the doubt surgery, the doubt about outcomes. So important thing in my about glitch. So I was saying that cancer management, the key lies if you can detect them much early. Now, if I share with you one data which I just published this month, this is the data of cancer registries in our country. There's a data of more than 50,000 patients with GI cancers and GI and liver cancer. And almost more than 70% when they presented, they already had a loco-regional spread. And many of them were incurable. So this is what the state of affairs of in our country. All of physicians, specialists must sensitize that to Dr. Assis to introduce the first speaker and then move forward.
Dr. Piyush,
Assis.
I would like you to introduce the first.
Okay, Piyush.
So we start with Dr. Pramod Garg. Dr. Pramod Garg is a professor at All India Institute of Medical Sciences. He's in the gastroenterology fraternity. He does not need any introduction to the general physicians. His keen area of interest is in pancreas, so it is quite befitting that he would be speaking about pancreatic cancers, and I'm sure he'll take you through the entire spectrum of the presentation of pancreatic cancers and how do you deal with it, especially as a general physician. How do you detect it? How do you refer it in time? So over to you, Dr. Pramod Garg, sir.
Thank you. Thank you very much, Ashish, for having invited me to this India chapter of American College of Physicians meeting on GI cancers. And as mentioned, that I'll be discussing about pancreatic cancer, its diagnosis and treatment. My talk would be largely, attracting the general physicians and internists who might be seeing pancreatic cancer in their day-to-day practice. So this is a classical scenario. A 61-year-old male presents, he's a top business, he's a smoker, undergoes regular health checkup, recently detected diabetes. He presented with abdominal pain for about 3 months. And his CT was done for evaluation of this abdominal pain, and a large pancreatic mass was found, which was unresectable. And I can tell you, this is not an uncommon situation. Someone comes to you with a short history, about 3-4 months, and you find an unresectable pancreatic cancer here. It was stage 3. He goes to Johns Hopkins. He's a rich man. He had a complete sequencing of the tumor done, tries out some new therapy, but he was dead within 6 months. Now, this tells you how pancreatic cancer actually presents in the general population and how fast it grows and how late it is diagnosed. And as of today, we really do not have a very satisfying therapy for this tumor. The incidence of pancreatic cancer varies from 2 to 10 per 100,000 population. In the United States, it is 4th leading cause of cancer deaths, and with a 5-year survival of less than 10%. In India, the incidence of pancreatic cancer is around 2 per 100,000 population, somewhat lower than many Western countries. Now, if you have to really prevent pancreatic cancer or diagnose it early, we need to understand the risk factors of pancreatic cancer. And if you look at the risk factors, they can either be modifiable, for example, lifestyle factors such as smoking, metabolic factors such as diabetes and obesity, underlying chronic pancreatitis, non-vegetarian diet, and a few drugs. Or they could be non-modifiable risk factors such as underlying genetic polymorphisms. And these could be either hereditary or familial or de novo. Now, we conducted 2 studies. One is a case control study and a cohort study to understand the risk factors for pancreatic cancer. And in a case control study, we included 249 patients with pancreatic cancer and 1,000 healthy controls. And we found on multivariable analysis, chronic pancreatitis, diabetes, and smoking were the most important risk factors. In a cohort study of 402 patients with chronic pancreatitis with a mean age of 29 years, we followed them up, and with their follow-up person years of 3879, we found 5 of them developed pancreatic cancer, giving a standardized incidence ratio of 121. That means chronic pancreatitis was a very high risk factor for pancreatic cancer. Three main factors were found to be important: diabetes, chronic pancreatitis, and smoking. And if you look at the population attributable risk, that means what percentage of cancer in the population can be attributed to each one of these factors. It was almost 9% for diabetes, smoking, and chronic pancreatitis. That also means that about 70% of cancers, we really do not know the underlying risk factor, major risk factor causing pancreatic cancer. And that is a hindrance when we talk about prevention of this deadly cancer. Of these factors, many studies have been conducted, and a meta-analysis of 36 studies showed diabetes has a risk ratio of 1.5. Obesity, again, has a risk ratio of 1.16. And smoking, again, in a meta-analysis of 82 studies, 75% had increased risk of developing pancreatic cancer. Among the hereditary risk factors, hereditary pancreatitis, there is a 40% accumulative risk of pancreatic cancer by age 70. And among those who have familial history of pancreatic cancer, which constitutes about 7 to 10% of all pancreatic cancers, there are many germline mutations which increase the risk of developing pancreatic cancer. In terms of its diagnosis, clinically, most patients would present either in the 6th or 7th decade of life. Abdominal pain is the most common presentation. Weight loss, again, is a common presentation. In fact, someone comes to you with unexplained weight loss. Among the malignancies, pancreatic cancer is one of them. Recent onset diabetes is, again, could be an indicator of underlying CA pancreas. In fact, someone comes with recent onset of diabetes and weight loss, I would suggest that you should definitely screen for pancreatic cancer. Some patients present with acute pancreatitis without any identified cause of pancreatitis. So someone comes, say, at the age of 55 years with the first episode of acute pancreatitis, and you do not find any definite cause of that pancreatitis, rule out pancreatic cancer for sure. And in fact, some of these patients need to be followed up for 3 to 6 months before you can diagnose pancreatic cancer as the cause of acute pancreatitis. And some of these patients may actually present asymptomatically. And asymptomatic is the diagnosis is incidental. And how they are picked up? They are picked up on imaging. On imaging, two things can be seen. Sometimes a patient may come for some other symptoms, undergoes an imaging like a CT or MRI, and you find the pancreatic duct is slightly dilated. This calls for further investigations. This is not chronic pancreatitis. And some patients may have cystic lesion in the pancreas, suggesting a cystic neoplasm. So for example, here a CT scan showed a mildly dilated pancreatic duct here, right? So we cannot just leave it like that. We have to investigate further to see whether or not there is a very small subtle lesion which is causing pancreatic ductal dilatation, and this could be ductal adenocarcinoma. The other incidental could be, for example, in this patient on MRI and MRCP, you find a small cystic lesion. This is a branched duct IPMN. So incidental diagnosis of pancreatic cancer can sometimes be seen. So how do you make the diagnosis of CA pancreas? And for this, best is imaging. Tumor markers, for example, CA99 really do not provide a definitive diagnosis. They may be helpful in some situations, but doesn't really help in making the final diagnosis. And among the imaging tests that we have, a contrast-enhanced CT scan is the first investigation of choice. It provides you with diagnosis and also staging of the tumor. MRI with the MRCP is also helpful, but is not required in all the cases. So we rely mainly on a contrast-enhanced CT scan for the diagnosis and staging. Another imaging which is very, very useful is an endoscopic ultrasound, which is excellent for diagnosing the lesion, in assessing resectability, and if required, which is required now more often, is to confirm the diagnosis by doing FNA. So in general, we say a histological diagnosis is not required if someone has a resectable lesion and undergoing surgery directly. But if someone is scheduled for a neoadjuvant chemotherapy or palliative chemoradiotherapy, then a histological diagnosis is required. In that case, EUS guided FNA provides the best answer. So comparison of EUS with CT and MRI has shown that for smaller lesions, EUS scores, it is much, much better than CT or MRI. In fact, the sensitivity may be as high as 99 to 100%. And of course, it also provides you with an opportunity of doing guided FNA. And one of the important things is that when you do FNA of any tumor, for example, there is a risk of tumor seeding. But in the case of EUS guided FNA, if you do it from the duodenum, the risk is not there, because these patients, when they undergo surgery for curative surgery, the tract is actually resected out. So there is no risk of tumor seeding if you do EUS guided FNA in the head of the pancreas. If the lesion is in the body and tail, which is in about 10% of cases, then there could be a risk of seeding. And hence, most people do not advise to do EUS guided FNA for making the diagnosis in if the lesion is in the body and tail in patients who have a resectable lesion. So for assessing resectability, basically, as in all tumors, we do T and M staging, and EUS again is very helpful for both T and N staging. For M, we need a CT or MRI. And for T staging, T4 is important, where you see the major arteries are involved, SMA or celiac. That kind of rules out curative surgery. And there are many criteria which we use to assess whether or not the vessel is involved. And EUS has a very high specificity and diagnostic accuracy in assessing resectability of the tumor. But on CT scan, you can easily find out if a major vessel is encased by the tumor is in the body and tail of pancreas here, and encasing the celiac artery. As I said, EUS has actually very high sensitivity and specificity, and more surgeons now rely on EUS for final assessment of resectability. When we come to the treatment in the early stage of the disease is basically curative resection. When there is no vascular involvement, no nodal involvement, you have a small tumor, then curative resection is possible. But unfortunately, that happens in less than 10% of cases. If you have a borderline resectable, and borderline resectable means that either a vein is involved partially, or you're not sure about the arterial involvement, then nowadays the current trend is to do a trial of neoadjuvant chemotherapy, with, for example, FOLFIRINOX. And after 3 months, you restage the disease. And if you find that the lesion has regressed, then consider curative surgery. In most of the other cases, which is about 80 to 90%, we only offer palliative therapy. Curative therapy is unfortunately not possible. When we talk about palliation, there are 3 things that these patients might be having. One is jaundice. In fact, in gastroenterology practice, we find more patients presenting with abdominal pain and jaundice. Second is pain, and third is gastric outer obstruction. If the tumor is really advanced, it causes gastric outer obstruction. And all these 3 problems, jaundice, pain, and gastric outer obstruction, leads to decreased nutrition. So we really have to take care of their nutrition as well. So in patients who present with jaundice, endoscopic drainage of the biliary drainage is indicated. For pain, we either give narcotics or sometimes do neurolysis, and which is again an EUS guided celiac plexus neurolysis. For gastric obstruction, you can do either a surgical bypass if a patient is young and surgically fit, but most often nowadays it is treated endoscopically by placing a stent across the obstruction in the D1, D2 area. Some people are also doing EUS guided gastrojejunostomy, but I think we need some more experience and data with regard to EUS guided gastrojejunostomy. But more often, we end up doing endoscopic placement of a stent across the obstruction. When we talk about drainage in patients who present with jaundice, the question is, does everybody require drainage or not? So the classical indications are a symptomatic patient who has got pruritus, who has got cholangitis, and whose quality of life is not good. But another major indication which is coming up now is palliative chemotherapy. So those patients who have jaundice and you find the tumor is not resectable, you plan palliative chemotherapy. If the bilirubin is more than 3, most oncologists will not like to give chemotherapy. And that's why you need to do biliary drainage and decrease the bilirubin to less than 3 before palliative chemotherapy can be started. And currently, most patients, in most patients, we end up doing endoscopic drainage, internal drainage, by placing a metal stent. You can also place a plastic stent if the patient's general condition is not good and the expected survival is less than 3 months. Then plastic stent should be okay. But most patients nowadays, particularly those who are planned for chemotherapy, a metal stent provides better drainage and longer patency. So, ladies and gentlemen, I'd like to summarize by saying that pancreatic cancer is uncommon, but it's fatal. Early diagnosis is important, but unfortunately is difficult. Prevention, of course, is ideal, but currently it's not possible because we really do not have the means of preventing the cancer. We do not really know the risk factors in large majority of patients. I showed you the population attributable risk in only about 27, 28%. In rest of the cases, we do not know the risk factors. Surveillance is indicated only in high-risk group of patients. For example, those with familial history of cancer and possibly in those with hereditary chronic pancreatitis. But in the general population, we have no guidelines or data to suggest that surveillance is helpful in early diagnosis. I'd like to thank you for your kind attention and happy to take any questions.
Thank you, Dr. Pramod. Actually, we'll be having question answer sessions at the end of the session. So I would like you to stay until that. So for the next topic, I would like to invite Dr. Vikas Singla. Dr. Vikas Singla is a well-known gastroenterologist, and presently he's the director and head of the Max Center of Gastroenterology and Hepatology at the Max Hospital, Saket. He was trained at All India Institute of Medical Sciences and Dr. Govind and Dr. Pramod Garg. And after AIMS, he joined Gangaram Hospital and he spent here about 8 or 9 years. And then recently he moved to Max. Dr. Vikas is a well-known gastroenterologist. He's especially known for third space endoscopy, doing POEM procedures for achalasia cardia, and lot of more endoscopic interventions he's expert on. So I would like to invite Dr. Vikas to speak on gastric cancer. Dr. Vikas.
Good evening, everyone. At the outset, I'm thankful to Dr. Ashish and Dr. Anuj for the kind invitation. It's an honor for me to speak in a session which is chaired by my teacher, Dr. Govind Makaria. And it's again an honor for me to be a co-speaker with my teacher and mentor, Dr. Pramod Garg, who taught me every skill in the endoscopy and gastroenterology. So gastric cancer is the 5th most common cancer worldwide, and it has high mortality. If we see the cancer-related mortality, it's the 3rd most lethal cancer. And there is a Eastern and Western variation. It's more common in the Eastern countries across the globe. It's more common in China and Japan. And even in India, it's more common in the Eastern India and few areas of Jammu and Kashmir. So I will be discussing the risk factors and the symptoms of gastric cancer, followed by diagnosis, staging, and the treatment. So the upper panel shows the definite risk factor for the gastric cancer. So H. pylori is the well-known risk factor for the gastric cancer. Gastric adenoma, that's a polyp with a dysplasia. It's a precursor for the gastric cancer. And cigarette smoking and certain polyposis syndrome, they are definite risk factor for the gastric cancer. High salt intake and obesity and the past history of gastric cancer, they are probable risk factor for the gastric cancer. And there may be some association with the tobacco and the high nitric intake for the gastric cancer. But of all these, the H. pylori infection is the most important risk factor for the gastric cancer. So H. pylori is a gram-negative bacteria, and it's the most common human infection by the bacteria across the globe. And when somebody has the H. pylori infection, it can be either a silent infection or there can be two types of phenotypes. So these two phenotypes are the duodenal ulcer phenotype and the gastric cancer type phenotype. So what are these phenotypes? So the first one is the duodenal ulcer phenotype. So in a patient with the H. pylori infection, the infection starts from the antrum. So in few patients, there can be increased gastrin release, and we know that gastrin release leads to increased acid production in the stomach. So if the H. pylori is confined to the antrum, it will lead to the hyperacidemia, and this hyperacid will enter the duodenum, and these patient will have duodenal ulcer formation. In few patients, the infection of the H. pylori, it moves up towards the gastric cardia and the fundus. So once the H. pylori has infected the fundus and the cardia, it will lead to the atrophy of the gastric mucosa. So once there is atrophy of the gastric mucosa, the acid production will be reduced in the stomach, and there will be intestinal metaplasia. And in a condition of hypoacidity, the innate defense of stomach against the bacteria is blunted, and there can be colonization of the stomach by various bacteria, which can increase the risk of gastric cancer. So in a normal gastric mucosa, first the H. pylori leads to superficial gastritis. This leads to a chronic state of inflammation. In few patients, there will be atrophic gastritis, and this will be followed by intestinal metaplasia. The gastric type of epithelium will be replaced by intestinal type of epithelium. It's called intestinal metaplasia. And few patients with the intestinal metaplasia, they will develop dysplasia and gastric cancer. So once a patient has gastric cancer, what can be the symptoms of gastric cancer? The symptom of gastric cancer may resemble a benign disease. Sometimes it's difficult to differentiate whether it's a benign disease or a gastric cancer. The most common symptoms are poor appetite or postprandial fullness. Patient feel full after taking a small meal. Few patients may complain of epigastric pain, and some patients may come to us with gastric outlet obstruction. If the tumor is involving the antrum, it can lead to the gastric outlet obstruction, and the patient can complain of vomiting of stale food and without any bile. So there will be no bile inside the vomitus, and there can be history of stale food. The patient can have vomiting of the food next morning after the intake of food, and few patients with the ulceration can have hematemesis or melena or chronic anemia. And the physical examination may be unremarkable in few patients. In few patients, there can be features of gastric outlet obstruction. If we see carefully, we can see the nodes in few patients in left supraclavicular region. There may be umbilical nodule. On PR examination, there can be a nodule on the Blummer shelf. There can be superficial thrombophlebitis or seborrheic dermatitis with the itching. That's a sign of lesser trillet. And there can be hyperpigmentation in the axilla or the neck area, known as acanthosis nigricans. So once we suspect the gastric cancer, how we confirm it? The upper GI endoscopy is the method of choice to diagnose the gastric cancer. So who should undergo endoscopy? So any patient whose age is more than 55 years and has a new onset dyspepsia should be suspected to have gastric cancer and should be referred for the upper GI endoscopy. If the age is less than 55 and patient has dyspepsia with the alarm symptom, the alarm symptoms can be GI bleed. Patient can have either hematemesis or melena or anemia, or there can be recurrent vomiting, weight loss, unintentional weight loss, and if there is a non-response to the PPI or the H. pylori eradication regime, and sometimes the patient can have dysphagia. If the gastric tumor is involving the G junction, it can lead to dysphagia also. So all these patients with age less than 55 but alarming symptom, they should also undergo the endoscopy to rule out the malignancy. So when we perform the endoscopy, we should be commenting on what's the extent of the tumor in the stomach, because that has a role in the final decision making, and we should also comment on the morphological appearance. So I will be discussing these. So first, when we are doing the endoscopy, we have to detect more early gastric cancers. As Dr. Govind mentioned, we are picking more cancer at the late stage. But if we pay attention carefully in each and every endoscopy, I think we can pick more early gastric cancer. And before doing the endoscopy, we should prepare the patient well. So during the endoscopy, there can be mucus or the bile form inside the stomach. So we always give the patient mucolytics. We give N-acetylcysteine and antifoaming agent, that can be simethicone. Now we have commercial preparation of mucolytic and the antifoaming agents. Patient has to just swallow a liquid prior to the endoscopy. Then we give the antiperistalsis. We use the Buscopan. So this preparation is mandatory so that we can see the gastric mucosa and we can pick up more lesions. So we can see two pictures. On the left side there is a lot of foam due to the bile. And on the right side, we can see the clear mucosa. In this patient, indigo carmine stain has been used. This is called chromoendoscopy. So if we use the dye during the endoscopy, this can increase the detection rate for the malignancy. So we have to give mucolytic and the antifoamic agent so that we can have a good view of the stomach. Then it's very essential to look for every part of the stomach. So these are the picture from the same patient. On the left side, it appears normal. But when we insufflate the stomach, we can see that there is a gastric cancer there. We can see a folds are converging towards one point. It indicates it can be a gastric cancer. So once we see such lesions, we have to take biopsy from the periphery of the lesion. And when we are doing the endoscopy, we should see every part of the stomach. This is a recommendation from the Japanese Society that we should document and take picture from each and every part. During antegrade view, we have to see the antrum, lower part of gastric body, mid upper body. Then we retroflex the stomach and we have to see again fundus, mid upper body and the incisura. So once we inspect each part of the stomach, the risk of missing the early gastric cancer can be lower down. And it's very essential to pick up early gastric cancer because they have excellent 5-year survival of more than 90%. So when we do the endoscopy, we first look for the precursor lesions. So as we discussed earlier, the atrophic gastritis and the intestinal metaplasia, it's a precursor lesion for the gastric cancer. So if we have a gastric atrophy during the endoscopy, then we have to be more careful to detect more gastric cancer. So we can see here, there is a alternate areas of the red and the white color. So this indicate there can be a gastric atrophy. These pale areas can be a gastric atrophy. And during the same setting, we can use the narrow band imaging. We can use the image enhanced endoscopy. Right now, endoscopy we are using red, green, and the blue light. So when we use the NBI filter, it will cut off the red light, and we will be doing the examination with the green and the blue light. Once we are using the only green and blue light, we will be getting better imaging of the mucosal lesions, and we can pick up more lesions, and we can define the nature of the lesion. And this is again the same patient. We can see pale and the red area. And this is the normal narrow band imaging of the gastric fundus. We can see here, this is the gland. This is the histopathology showing the glands. And then this is the opening of the gland. This brown dot is the opening of the gland, and this whitish area is the crypt epithelium. Thanks to advancement in the technology, during the endoscopy only, we can see the type of glands. When there will be malignancy or the metaplasia, this gland will change. So this is the normal fundus. We can see there is a hexagon appearance. And in the center of the hexagon, there is a dot. This dot is the gland opening. Again, on the magnified image, we can see a gland opening surrounded by the whitish epithelium. And on this image, we can see there is an increased distance between the gland opening. It means there is an edema of the gastric wall. This is H. pylori gastritis. Here, we cannot see any surface pattern. We cannot see any gland, but we can see only regular vessels. This is gastric atrophy of the gastric mucosa. And here we can see the glands there, but again, we can see there is a blue line, this is a light blue crest. So this is called LBC sign, light blue crest. If in the stomach we see this pattern on narrow band imaging, it indicates intestinal metaplasia, and this lining is due to intestinal villi. Normally gastric mucosa doesn't have villi. So once we have this light blue crest, it indicates there are villi on the gastric mucosa. It indicates intestinal metaplasia. So once we see this type of pattern, we should evaluate the whole stomach very carefully to find out the early gastric cancer in these patients. Now, when we see the tumor, we have to classify whether it's early gastric cancer or it's advanced gastric cancer. So early gastric cancer, by definition, they are confined to the mucosa and the submucosa. And for early gastric cancer, we have a Paris classification. Paris 1 is the elevated lesions, and Paris 2, we can see the other flat lesions, and Paris 3 are the ulcerated lesions. So early gastric cancer should be classified according to Paris classification, and more than 80% of early gastric cancer, they will be type 2C, they will be depressed. And when we are doing the white light endoscopy, we should see the surface, we should look for any color change, which is more contrast to the surrounding mucosa. We should look for the change in the light reflection. When we use the light, there is a reflection of light back from the gastric mucosa. If there is any change, we should notice that, and we should look for the area for the spontaneous bleed. If we look for the all four features, we can pick up more early gastric cancers. We can see here there is a small lesion, and when we use the chromoendoscopy, we can see there is a well-demarcated lesion and the surface is irregular. This is virtually diagnostic of early gastric cancer. If we can diagnose at this stage, this tumor can be removed with the help of endoscopy only. Again, another patient with early gastric cancer, we can see a well-demarcated area and there is an irregular color pattern, again suggesting the early gastric cancer. So once on the white light, we have suspected the early gastric cancer, we can, on the NBI, we can confirm the diagnosis also. Here on the white light and the chromoendoscopy, we can see there is a demarcated lesion with the irregular surface. When we do the NBI, we can see that this area is different from the surrounding area. And here the vessel caliber is irregular. We can see small vessel and the large vessel together. So this is called vessel irregularity, and this is diagnostic of early gastric cancer, and this can be confirmed on the NBI. Another type of cancer is the advanced gastric cancer. It means they have grown beyond the muscle layer, and on endoscopy, they can be classified into the four patterns: Borman type 1, 2, 3, and 4. Borman 1 are the polypoidal lesions. Borman 2 are the fungating lesions. These two have the better prognosis. Borman 3 is the ulcerated, and Borman 4 is the infiltrative. It's a diffusely infiltrate the gastric mucosa, and the stomach becomes constricted stomach with a very low capacity. It's called linitis plastica. So Borman 4 is the linitis plastica, and it has a very poor prognosis. So during the endoscopy, first on the white light, we have to detect the lesion, and we can use either the conventional chromoendoscopy with the indigo carmine, or we can use the digital image enhanced endoscopy such as NBI, which can characterize the lesion and demarcate the early gastric cancer. So once we have diagnosed a lesion, the next step is the staging of the lesion, and the most commonly used staging in the TNM staging. It depends on the locoregional spread and the metastatic spread. And for this, we can use the four modalities: endoscopic ultrasound, CT scan, PET scan, and the staging laparoscopy. As Dr. Garg mentioned, initially EUS came for the pancreas, and then gradually the indications expanded, and gastric cancer is one of the indications where we can do the EUS, where EUS can play a very crucial role. And here on the radial imaging, we can see there are 5 layers. We can see 3 white layers, this first white layer, and the second white, and the third white. In between the 2 white layers are the black layers. Black layer are the muscle. The first 2 layers belong to the mucosa. The third layer belongs to submucosa, and the fourth layer is the muscle layer. If the tumor has gone beyond this third white layer into the fourth layer, it means it's a T2 tumor. If the tumor is confined to the first 2 layers, it's a T1 tumor. It's very essential to demarcate this, because T1 tumors, they can be cured either with the endoscopy or the partial gastric resection. But if the tumor has gone beyond the T2 stage, it has entered the muscularis propria, these patients will require more extensive surgery, and they will require the palliative or the neoadjuvant or post-surgery chemoradiotherapy also. So here we can see we can see the black, mostly tumor, they appear as the black lesions. And here we can see tumor is extending up to the submucosa only, and the underlying muscularis propria is intact. It indicates it's a T1 tumor only, and it can be removed with the surgery without any need of the chemotherapy. And on this, we can see tumor has gone beyond the adventitia. The outermost layer is the serosa, and it has gone beyond the serosa into the surrounding tissue. So it's a T4A tumor. And this tumor has a bad prognosis as compared to this tumor. And the next imaging is the CT imaging. Most commonly used modality for the staging is the CT because it's widely available. And if we compare loco-regional staging, CT scan is inferior to EUS to define the loco-regional stage. But when it comes to distant metastasis, CT is better than the EUS, and it can detect more than 85% of distant metastasis. So here we can see there is a tumor in the gastric antrum. And this is the tumor area. So once we see the tumor, we have to see what's the relation with the surrounding organs, what's the relation with the liver or the pancreas, and we have to define the various lymph node stations. If the tumor is invading the liver, or it's invaded, or there is a bulky lymph node metastasis, that's an indication for the neoadjuvant. These patients again has a poor prognosis. PET has a limited role in case of gastric cancer because most of the gastric cancer, they are not PET avid, and for local staging it's a very poor, then it's poorer than the CT scan because of low resolution. But for the distant metastasis, it can pick up 10% more metastasis as compared to CT scan. And if after the neoadjuvant therapy there is a PET response, it indicates there will be better survival compared to patients who are non-responsive to the neoadjuvant therapy on the PET scan. And the staging laparoscopy, it can pick up the metastasis in around 25 to 40% of patients. So prior to the surgery, it's always good to do staging laparoscopy if there is and one can pick up the metastasis, peritoneal metastasis, in around 25% of cases, and the management will change in these patients. So once we have done all the modalities, the tumor will be classified on the T and M staging and will be treated further. So if it's a T1 tumor, it can be removed either with the endoscopy or the partial gastrectomy. If it's a T2, T3 or T4 tumor, T2 means it has gone beyond the, it has gone into the muscle layer or the lymph node positive. If it's a resectable tumor, the tumor which are not involving the retroperitoneum or limited lymph node disease, they are resectable lesions. So now there are two schools of thought. These patients either can directly go gastrectomy or they can undergo neoadjuvant chemotherapy followed by surgery. So either can be chosen depending on the center practice. Most of the centers, if the patient is resectable, they offer upfront surgery followed by the chemotherapy. Now, few centers have starting neoadjuvant chemotherapy on all the patients T2 and beyond, but that will increase the cost of the treatment. And as I mentioned, the T1 tumor, which are confined to the mucosa, they can be removed with the ESD. ESD is the endoscopic submucosal dissection, and or the EMR. These are two endoscopic techniques which can cure the gastric cancer, provided it meets certain criteria. If it's a well-differentiated tumor, which is less than 2 centimeters, it can be removed with the endoscopy. Here we can see a video of such case. We can see a flat lesion, early gastric cancer in the antrum. So first we mark the tumor all around, then we lift the tumor with the injection. So we inject a solution below the tumor to lift the tumor from the underlying submucosa. This tumor is confined to the mucosal layer, and the lift is due to the fluid in the submucosal layer. Then we give an incision all around the tumor. It's a circumferential incision. And then here we can see the bluish structure. This is submucosa. Then layer by layer, this blue structure is cut and the tumor is removed. If on histopathology, this is well-differentiated tumor without lymphovascular invasion, this endoscopic treatment is curative. The patient doesn't require anything more than this. Surgery, the patient will either undergo subtotal or the total gastrectomy. If the tumor is confined to distal part, the subtotal gastrectomy will be done. And if it's a proximal tumor, the patient require the total gastrectomy. And if the adjacent organs are involved, the surgery becomes difficult. For bulky nodal disease, neoadjuvant is offered, and prior to every surgery, the staging laparoscopy should be done in the same session, and minimum 14 nodes should be removed during surgery to define the stage. And chemotherapy has a definite role in the management of these patients. After the removal of tumor, most of the patients, they will require the adjuvant chemotherapy or the chemoradiotherapy. If the lesion is unresectable, the patient and the functional status is good, most of the patients, they are treated by chemotherapy. The chemotherapy is mostly 5-fluorouracil or the cisplatin based. If patient is non-responsive to chemotherapy, the next step is the targeted therapy. If the tumor is showing HER2 positive, then the trastuzumab is used, and now there is coming role of the immune therapy like nivolumab. It's a PD-1 inhibitor. So once the PD-1 is inhibited, it will increase the immune response against the tumor, and it can increase the survival. So to summarize, H. pylori is a definite risk factor for the gastric cancer, and intestinal metaplasia and the atrophy are the precursor lesions. Upper GI endoscopy is the gold standard to diagnose gastric cancer. If we are more careful during the endoscopy and using the image enhanced endoscopy, we can detect and diagnose the early gastric cancer. EUS and the CT scan are the major tools for the staging. EMR and ESD, they can be curative for the early gastric cancer. For advanced cancer, surgery is the standard of care, and adjuvant and the neoadjuvant chemoradiotherapy has a definite role in the management of these patients. Thank you very much for your patient hearing.
Thank you, Dr. Vikas, for that excellent lecture. I would like to invite Dr. Govind to give you an overview of the last two talks.
Yes, I think the last two talks, pancreatic carcinoma by Dr. Pramod Garg, and then carcinoma by Dr. Ashish. They both have been wonderful talks, talking about the basics, when to suspect, and then how to make diagnosis, and the overview on the treatment of these two conditions. We all know that by the time pancreatic carcinoma presents to us, mainly with jaundice or pain of abdomen, the tumor is already advanced. So and the point to note that all patients, the most important risk factor, which Dr. Garg told us, that chronic hepatitis is one of the most important risk factors. So all patients with hepatitis should be put on surveillance for malignancy. So this is one takeaway. And second thing, what he told, that if we have some elderly person have recent onset diabetes, think of pancreatic cancer is there. So there are two important points to learn. The second point, the third, this is regarding the carcinoma stomach, that many patients will come with dyspepsia. If you have dyspepsia, any late onset dyspepsia, say 50 years person come with dyspepsia or 60 years person come with dyspepsia, just don't treat by giving PPI or S2RA. Think that this could be an early malignancy. And Dr. Singla showed very nice videos that how can you pick up early lesion. Early lesion, you can treat, their curative resection can be done through endoscope. By the time patient come with either gastric outlet or inlet obstruction or satiety, which are features of advanced lesions, then we have a limited treatment options. So keeping in mind the picking up the disease early is the key to a good treatment for many cancers. And lastly, Dr. Singha told that H. pylori is one of the very important risk factor for gastric cancer. And we know that in our country, almost 60 to 70% of healthy people will have H. pylori. Many will have so once you decide to treat H. pylori, treat them appropriately. There's a lot of increasing incidence of clarithromycin drug resistance. So simply, if you want to treat H. pylori, treat them appropriately. With that, let me invite Dr. Piyush to call the next speaker.
Thank you, Dr. Govind, for this excellent summary of the previous two talks. Now we move on to the third talk, and then we'll take questions. For the third talk, we have Dr. Ashish. Dr. Ashish is a senior consultant in Gangaram Hospital, New Delhi. He has done his DM from SGPGI and he was my colleague there. And since then, I have seen him grow in the ranks of academics. He has got a number of published papers. And in fact, he is one of the co-authors of the HCC guidelines by the Indian National Society. And I'm sure he's the best person to present this topic. And over to Dr. Ashish.
Thank you, Dr. Piyush. Are my slides visible? My slides are visible?
Yes, they are visible.
Okay. Thank you, Dr. Piyush, and thank you, Dr. Anuj Maheshwari, for inviting me to talk about liver cancer in this American College of Physicians India chapter. So I would give a brief overview of liver cancer approach to the management. But before I go on the approach, I would like to present few cases. So this is the first case, a 47-year-old lady who presents with hematemesis and melena. And on examination, there was nothing positive except some anemia and splenomegaly. And on investigation, the endoscopy showed large esophageal varices. Her HBsAg hepatitis B viral marker was positive, and ultrasonography showed shrunken nodular liver with a dilated portal vein. So the diagnosis of cirrhosis, which was hepatitis B virus related, was made. And since her liver function test and she did not have ascites, liver function tests were normal. So she was labeled as child A cirrhosis. So she was given treatment in the form of endoscopic variceal ligation and antiviral treatment. And with this, she got better and then she was lost to follow-up. Subsequently, about 3 years later, she again presented, and this time she presented with pain abdomen, jaundice, and tense ascites. And at this time, ultrasound showed, apart from ascites, it showed 5 centimeter space occupying lesion in the right lobe of liver. Her alpha fetoprotein, the tumor marker for the liver cancer, was 8,700. The normal values are less than 40. And then this time the diagnosis was made as hepatocellular carcinoma, along with cirrhosis, which she already had, hepatitis B virus related. And now her condition is that she's child C cirrhosis with advanced liver disease. Coming to the second case, this is a 55-year-old male who's a chronic alcoholic. And now he presents with abdominal distension and pedal edema along with jaundice. And he has been drinking till very recently. On examination, there's icterus and ascites. And on investigation, ultrasound shows nodular liver ascites. Liver function shows bilirubin of 4.5, low albumin level. And the diagnosis of cirrhosis, which is alcohol related, is made. And since he has already jaundice as well as ascites, so it's a decompensated cirrhosis, child C status. So he's advised abstinence and he's given diuretic and therapy and other supportive measures. And again, he now comes again 1 year later, and then he presents with tense ascites, jaundice, and this time his ultrasound shows multiple space occupying lesions in both the lobes of the liver. Alpha fetoprotein is normal, although, but we order a triple phase CT scan abdomen, which show that all the space occupying lesions enhance in the arterial phase, and there's a washout in the venous phase, and so a diagnosis of hepatocellular carcinoma in the background of cirrhosis, child C status is made again. Coming to the third case is of 65-year-old male, obese, diabetic for 8 years, and he just presents with loss of appetite and a dragging pain in the left upper quadrant in the abdomen. On investigations, his anti-HCV is positive and his hepatitis C viral load is 10 to the power 7 international units. His alpha fetoprotein is normal. Ultrasound shows irregular nodular liver along with a space occupying lesion about 9 centimeter. And again, we order a triple phase CT scan, which shows the SOL, which enhance in arterial phase and wash out in venous phase. Again, a diagnosis of hepatocellular carcinoma with the background of cirrhosis, but this time a child A cirrhosis is made. So what is common in all the 3 cases? So all the 3 patients had underlying cirrhosis. All the patients present with HCC, which is fairly at advanced stage. The first two patients present with HCC, liver cancer, along with advanced liver disease. The third patient presents with a large tumor, which is also beyond curative therapy. So all the three present with HCC at an advanced stage. And the tumor markers AFP is not very reliable because in two of the cases it was normal, and in only one it was high. So who gets hepatocellular carcinoma? So what are the risk factors for hepatocellular carcinoma? The most important risk factor for hepatocellular carcinoma or the liver cancer is the cirrhosis of the liver. So cirrhosis can be of any etiology. It could be due to hepatitis B virus related. It could be hepatitis C related. It could be a non-alcoholic steatohepatitis, NASH, or it could be alcohol, or it could be of any other etiology. It could be Budd-Chiari syndrome. It could be autoimmune liver disease, or it could be any etiology. But if there is cirrhosis, then this patient is definitely a risk factor for having a hepatocellular carcinoma. Along with cirrhosis, there are certain contributory factors. For example, if the patient has coexistent diabetes, or if he's consuming tobacco, if he's smoking, or if he's having aflatoxin, then all these conditions also contribute to the development of hepatocellular carcinoma. But the most important risk factor remains as cirrhosis of the liver. This was a recent study which was published from PGI Chandigarh, and it was a very large study of about 800 patients, and this gives a very good overview of what kind of patients present with hepatocellular carcinoma. So this was a study of about 800 HCC patients, and what we see that in about 86% of patients there is underlying cirrhosis of the liver, so which is a most important risk factor. The most common age of presentation is around the 7th decade. That means age between 60 to 65 or above 50 years of age. Most of these patients are male, so it is a male predominant disease. And about 1/4 of these patients already have diabetes, which is contributory factors. The symptoms are not very specific. Some patients may present with loss of weight or appetite. Some patients present with abdominal pain. Some patients present with jaundice. But one important thing is that most patients present at late stage. We commonly do the staging according to the Barcelona staging, and the stage A, only 22% patients had presented in stage A, which has got curative therapy possible. And about 80% of the patients present late in the stages B, C, or D. So as I told you, the most important staging system of the hepatocellular carcinoma is Barcelona staging or BCLC staging. And it takes into account three things. One is the liver status. The other thing is tumor status, and third is the performance status. So if the liver status is child A or child B and child C, accordingly the staging is done. Tumor stage depending on the number and size of tumor, and performance status if he's very looks healthy and is moving all around, then his performance status is good. Or if he's bedridden and if he's confined to a wheelchair, then he has bad performance status. So depending on these, there are 4 stages are there, 5 stages are there. One is very early stage or stage 0, early stage, that is stage A, intermediate stage or stage B, C is advanced stage, and D is the terminal stage. And depending on these stages, the survival is also there. In very early stages, the 5-year survival may be more than 70%. In early stages, it is 40 to 70%. And in the intermediate stage, it is about 19-20 months. In advanced stage, it is about less than 1 year, and in terminal stage is less than 3 months. And depending on these stages, the treatment also depends. For in very early stage or in early stage, curative treatment for the liver cancer is available. But for intermediate stage, advanced stage, and terminal stage, only palliative treatment is possible and curative treatment is not possible. So we have 2 facts now. The first fact is what I presented is that cirrhosis is a predisposing condition for development of HCC. The second fact is that early detection of HCC, that is in stage A, has the better chance of cure and survival. Like in any cancer, if it is detected early, it has better chances of survival. So if we combine these 2 factors, then there is a definite role of surveillance. So if the patient of cirrhosis is there, if we are following these patients, and if we can do screening in these patients, then we can definitely detect early detection of liver cancer in these patients. So almost all the liver societies recommend that surveillance is an important part. HCC surveillance in patients with cirrhosis can detect early tumors that are potentially amenable to curative treatment. And how we should do surveillance, and it is recommended that we should do 6 monthly ultrasound abdomen by experienced personnel who is experienced in detecting liver tumors, which is recommended at every 6 months. And alpha fetoprotein, the tumor marker, can be added, but alone AFP is not a reliable marker for surveillance. So 6 monthly ultrasound along with alpha fetoprotein is the best modality for surveillance in these patients. So when we do ultrasound of a cirrhotic liver, what we see is that there's a rough liver margin, there could be ascites, and there's a heterogeneous enhancement of the liver, cirrhotic liver tissue. But when there is a space occupying lesion, it is hypoechoic lesion which is seen. So whenever a space occupying lesion is seen in on ultrasound in any cirrhotic liver, then the differential diagnosis would, the number one would be HCC, but it could also be regenerating nodule, it could be dysplastic nodule, focal fatty infiltration, adenoma, hemangioma, metastasis, cholangiocarcinoma. So we have to rule out all these conditions whenever we detect a space occupying lesion in a cirrhotic liver. So how do we do that? Do we do a FNAC or do we do a CT scan? The answer is that the best modality for detecting liver cancer in a cirrhotic liver is a CT scan. So what we do is a triple phase CT scan of the abdomen, which is the investigation of choice for diagnosis of HCC in a cirrhotic liver. The characteristic finding in triple phase CT scan is enhancement of the nodule in the arterial phase and washout in the portovenous phase. So what are these? I would like to tell you now. So as we all know, the liver's blood supply is from 80% from the portal vein and 20% is from the hepatic artery. So whenever we do a CT scan in a normal liver, when we inject contrast, the liver will enhance whenever the contrast will reach through portal vein. So it will enhance in the portal venous phase. But what happens when there is a hepatocellular carcinoma, HCC? HCC blood supply is predominantly from the hepatic artery. So this, because of this factor, so whenever we do a contrast enhanced CT scan in a cirrhotic liver with an HCC, the HCC will enhance during the arterial phase, the early phase. And during the portal venous phase, when the rest of the liver is enhancing, that time it will not enhance. So in relatively, it will appear as if the enhancement has washed out. So this the phases of triple phase CT scan. This is the first phase, that is non-contrast CT scan, where none of the lesions are enhancing. But when we give contrast through in the arterial phase, the hepatocellular carcinoma tumors are enhancing, that is in the arterial phase. But once the contrast reaches through portal vein, the rest of the liver enhances, but now the contrast is not in the arterial phase, so this appears as washout, and in the late phase all becomes isodense. So this is called triple phase CT scan abdomen, and for detection of HCC, this is the best modality in patients of cirrhosis. So again, this is in the arterial phase, it is enhancing. In portal venous phase, it is washed out, and in equilibrium phase, all are become equal. The HCC is characteristic lesions because it will show enhancement and washout in the enhancement in the arterial phase and washout in the portal venous phase. All other differential diagnosis which I mentioned, like adenoma, hemangioma, metastasis, cyst, will not have this characteristic feature on the CT scan. Now, once we have diagnosed hepatocellular carcinoma, we do the staging. As I already told you, we do the staging. The commonly done staging is through Barcelona Clinic Liver Cancer Staging, or BCLC staging. It takes into account three things: liver function, performance status, and tumor burden, as I already told you. So Based on the BCLC staging, the survival also depends. In very early stage or early stage, when the tumor is small and performance status is good and liver functions are good, that survival is more than 5 years. But as the staging advances, the survival deteriorates. And the treatment is, so this staging not only tells about survival, it also dictates how we should treat these patients. So the treatment of liver cancer is actually multimodality, and depending on the stage, we give the treatment. For very early stage and early stage, the treatment of choice are ablation, where we ablate the tumor, or resection, we do surgical resection of the tumor, or we do liver transplantation. For the intermediate stage, we do a procedure which is called as transarterial chemoembolization. I'll come to detail about it. And for advanced stage, we give systemic chemotherapy, or we also do transarterial radioembolization. And for terminal stage cancer, we only can give best supportive care, because none of these treatments are tolerated by these patients. So coming to the first type of treatment, which is done in early stage or very early stage, that is the curative. One is ablation, resection, and liver transplantation. So what is ablation? Ablation can be done by two methods, either by chemical method or by energy method. By chemical method, we inject either ethanol into the liver tumor percutaneously, or we also may inject acetic acid. So this is we ablate the tumor. This is done for a small tumor, 2 to 3 centimeter in size. But nowadays, this has been replaced by energy mediated ablative method, most commonly done through radio frequency ablation, where heat is generated inside the tumor, or microwave ablation, or even cryo ablation, where cold therapy is given. So how is ablation done? So for ablation, we percutaneously we introduce ablative needle. This is a radio frequency ablative needle, which is introduced percutaneously through the liver, and it has got multiple probes, and these probes are released, and these generate radio frequency, which leads to heating of the tumor, and then it leads to charring or the burning of the tumor. And then the track is also ablated, so that the tumor track, there's no tumor track seedling. So this is ablation. But ablation has to be done only in patients which have got small tumor and which are located at a favorable location in the liver. The next modality which can be done in these patients, if the tumor is small, that is resection, that is surgical resection. So we can do a wedge resection of the tumor if it is located in the periphery. We can do a sectional resection. We can do even remove half of the liver, that is left hepatectomy, or a segment of the liver. But whenever we do resection, we must ensure that the residual liver tissue is adequate to take over the function, and there is no portal hypertension. So we have to very carefully choose these patients, that they don't have clinically significant portal hypertension, they are not bleeders, they don't have significant varices, and their portal pressure is not very high, and their tumor is small, so that the residual liver tissue is healthy enough and which can take over the function after the resection. So this is a resection. And the third important curative treatment is the liver transplantation. And the most commonly used criteria for liver transplantation, that means when do we subject these patients for liver transplantation, is called Milan's criteria. It was developed in the city of Milan. The Milan's criteria states that either the tumor is a single tumor in the liver, which is not more than 5 centimeter, or if there are multiple tumors, they are not more than 3 tumors, and none of these tumors are more than 3 centimeters. So if the patient satisfies this Milan criteria, and apart from this tumor size and number, there should be absence of vascular invasion, as well as there should not be any extrahepatic spread. So portal vein or hepatic vein should not be involved, and the tumor should be either single, less than 5 centimeter, or it should, if they are multiple, they should be less than 3 and less than 3 centimeter in size. So if these criteria are met, then the liver transplantation is hugely successful, and these patients have got excellent 70-80% or 5-year survival rate. But sometimes the Milan's criteria is not met, and the tumors numbers are higher than what is prescribed by Milan's criteria. Then we may go ahead with the liver transplantation. But as the tumor number or as the tumor size progresses, thus similarly the success rate or the long-term survival will decrease. So these three, ablation, dissection, and liver transplantation, are the curative treatment for the liver cancer, HCC. Now coming to the when the tumor is of intermediate stage as per BCLC staging, and then the curative treatment is not possible. So what is the treatment? That the best treatment in this stage is transarterial chemoembolization, or TACE. So what is TACE? So in TACE procedure, we try, it's a kind of angiography procedure. We try to reach the liver tumor from the femoral artery. We reach the aorta, and from there we reach the hepatic artery, and we try to reach super selectively reach the tumor tissue, and there we inject chemotherapeutic agent as well as we embolize the hepatic artery, so that due to these chemotherapeutic agents like doxorubicin, epirubicin, which locally act on the tumor and they kill the tumor. And we also embolize the hepatic artery so that there is a ischemic necrosis of the tumor tissue. So this was the TACE procedure, which is done for intermediate stage. What about advanced stage? Advanced stage is said when there is either extrahepatic spread of the tumor, or the tumor is very large, or there is macrovascular invasion, that means portal vein or hepatic veins are involved. Then the only treatment possible is either systemic therapy or sometimes transarterial radioembolization. So transarterial radioembolization is similar to transarterial chemoembolization, but here we are injecting the radio labeled radioisotopes, usually yttrium-90, which give a local radiotherapy to the tumor. The other thing which we can do is systemic chemotherapy. And currently, the first line systemic therapy is atezolizumab and bevacizumab combination. The other drugs are lenvatinib and sorafenib. So atezolizumab is a monoclonal antibody. It is an immune checkpoint inhibitor. So immune checkpoints are recently discovered modality of treatment for cancers, where because of immune checkpoint, these the body is not able to mount an immune response to tumor, and so these monoclonal antibodies or immune checkpoint inhibitors are able to block these checkpoints. So atezolizumab is the immune checkpoint inhibitor, and it is combined with bevacizumab, which is an angiogenesis inhibitor or vascular endothelial growth factor inhibitor, and the combination of these two are given, which is given every 3 weeks. And recently in 2020, this trial was published, and which showed that with atezolizumab and bevacizumab combination, the survival was much better than the previously used chemotherapy, that is sorafenib. With this, there was a better survival, about 3 to 4 months of progression-free survival. Other therapies like lenvatinib and sorafenib have been there for now many years, especially sorafenib, more than a decade. Since 2007, it has been launched, and it has changed the HCC tumor treatment chemotherapy. With these with these chemotherapeutic agents, that means targeted therapy as well as immune checkpoint inhibitors, the median survival is now gradually increasing in these patients, since these systemic therapy is given to patients who have already advanced tumor, and now the survival is to the tune of 16-17 months, or even up to 2 years. What about second line and third line systemic therapy? Once the patient has received atezolizumab, bevacizumab combination, and if he has not responded, then he can be switched over to sorafenib or lenvatinib. If there's side effects, or if there's no response to these also, then there are multiple third line agents which can be switched over and which can help in prolonging the survival of these patients. So the take-home message for today's talk is the most HCCs occur in patients who already have cirrhosis. Hence, all patients of cirrhosis must undergo a 6-monthly ultrasound surveillance to detect any HCC development. And if this would help in early detection of liver cancer, and so that a curative treatment is possible. Any space-occupying lesion detected on ultrasound must be in a patient of cirrhosis, must be followed up with a triple phase CT scan for confirmation of diagnosis of HCC. The FNAC is usually not required for confirmation in a patient of cirrhosis. And alpha fetoprotein may or may not be elevated. And for the treatment, it depends on the staging. The most commonly used staging is Barcelona Clinic liver cancer staging, and a multimodality treatment is given depending on the stage. For usually other cancers, we only have chemotherapy, radiotherapy, and surgery. But for liver cancer, we also have liver transplantation. We also have ablative therapy. We also have transarterial chemoembolization. We also have transarterial radiotherapy. And now even stereotactic radiotherapy, or SBRT, is also coming up. So we have a multimodality treatment, but the most important thing is for early detection of these tumors. Thank you for your patient hearing.
Thank you, Dr. Ashish, for that wonderful presentation. And so with this, we finish all these talks, and the theme of all these talks have been early detection of cancer so that the tumors can be treated appropriately and curatively. And liver cancer, as Dr. Ashish mentioned, is different. Here you have a definite predisposing condition where we can do a careful surveillance and pick early tumors. And liver cancer is probably the only tumor where histopathology is not required. You can make the diagnosis only by a good triple phase CT scan. And as he mentioned, there are a lot of options available for all these treatment. And as all three speakers have pointed out, there are a number of newer therapies, these immune checkpoint inhibitors, PD-1 inhibitors, which provide good treatment options in the late stage of diseases. So with this, we start taking on questions. And the first question is for Dr. Pramod Garg. And there's been a question about the risk factor, or the importance of diabetes as a risk factor for pancreatic cancer. So how do we take it? So diabetes is a very common disease, sir. So all the diabetics, should they be closely followed up for development of pancreatic cancer, or particular subset of these patients are more prone to develop pancreatic cancer?
Thank you, Piyush. So, there has been some debate about diabetes and surveillance for pancreatic cancer. Diabetes is so common that there is no recommendation for screening all patients with diabetes. When we talk about diabetes and pancreatic cancer, there is a two-way relationship. One is that long-standing diabetes of more than 5 years is considered a risk factor. But that does not mean that everybody with a diabetes of more than 5 years should be screened for cancer. The second is that those who develop pancreatic cancer, they may present with new onset diabetes. So a new onset diabetes is another thing that is important. So the debate in the Western world, particularly in the United States, is that anybody who is above the age of 50, 55, who develops recent onset diabetes and has weight loss. So weight loss is important. By the way, those who have diabetes uncontrolled also develop weight loss. So it's not also specific for pancreatic cancer. But this is a subgroup which can be considered for some kind of screening. But as of today, there is no guideline to recommend screening in this general population. So when I say that diabetes is a risk factor, if you quantify the risk, it would be, as I showed you, the odds ratio of about 1.5 to 2. That means their risk of developing cancer would be, say, 50% higher or 60% higher than the general population. Now, in the general population, I told you that 2 per 100,000 population might develop pancreatic cancer. So in diabetics, it could be, instead of 2, it could be 3. So that is why the absolute risk of cancer is much lower, and hence a recommendation for surveillance is not, it's not recommended. Surveillance is not recommended.
Thank you, sir. So the take-home message is that you have a new onset diabetes, as sir showed in the case which he presented. A 61-year-old gentleman presented with new onset diabetes, had weight loss. So these non-specific symptoms, and age is a very important risk factor show. So we should be on lookout of not ignoring these patients as functional patients. Another question, sir, like Ashish mentioned, we all know cirrhosis is a risk factor. We all need to keep these patients in surveillance. And chronic pancreatitis is this ground where these pancreatic cancers would develop. So is there any recommendation of having surveillance in these patients with chronic pancreatitis?
So I think let's generalize this question. One, that most chronic inflammatory diseases have some kind of increased risk for cancer. And as you just mentioned, that chronic pancreatitis, cirrhosis, chronic esophagitis with Barrett's, IBD. So many chronic inflammatory diseases are there which have an increased risk of cancer. One thing we need to understand is that the duration between the onset of a chronic disease, for example, chronic pancreatitis or cirrhosis, to development of cancer is rather long. It is at least about 10 to 15 years in most cases. Second is that surveillance is often difficult. Screening is often difficult, particularly for patients with pancreatic cancer. It is difficult to pick up the lesion in the early stages, more so in those who have chronic pancreatitis. So what others have shown, and we have shown, that chronic pancreatitis, which is idiopathic in etiology, and when I say idiopathic in India, it is largely genetic. That means in about 50 to 60%, you have some genetic mutations, particularly SPINK1. These are the patients who are at higher risk. We have found that alcoholic chronic pancreatitis is not generally a risk factor. But if you follow these patients up for 15 years, 20 years, they also might develop cancer. So in the case of chronic pancreatitis, the only subtype where it is recommended to do surveillance is hereditary pancreatitis. As I showed you in my talk, that there is a cumulative risk of 40 times than compared with the general population. And that is why many people recommend that those above the age of 50 years having hereditary pancreatitis may undergo yearly some imaging like an abdominal ultrasound or 3 yearly MRI or EUS scan. But the guidelines, again, they are not uniform.
Another question to you, sir, is that with the availability of imaging, you showed an image in which there was a mildly dilated pancreatic duct. We have a lot of ultrasounds which show small cysts, and we know that some of the cysts might be harbinger of malignancies. So what would you advise to general physicians?
So,
where should they refer to patients?
Very important question you asked, and I did refer to that in my talk, but my focus was on pancreatic ductal adenocarcinoma. So incidental diagnosis of pancreatic neoplasms is either pancreatic ductal carcinoma, as I said, mildly dilated duct. The other is a cystic lesion in the pancreas, which you are now referring to. When we talk about cystic lesions in the pancreas, the only thing we have to determine whether it is a pseudocyst following an attack of acute pancreatitis or chronic pancreatitis, or it is a true cyst. And true cysts, by and large, are cystic neoplasms. If you have a cystic lesion which is less than 3 centimeters in size and does not have some of the risk factor or some of the high risk features, for example, it does not have intramural nodule, it does not have thick septa, it does not have very thick content, we take it as a benign cyst. So less than 3 centimeter size, asymptomatic patient, absence of any high risk features, do nothing, observe. You may follow these patients up at 6 months or 1 year initially, and then maybe at 3 years to find out if the cyst is increasing in size or not, or if there is a worrisome feature developing or not. In that case, one can consider surgery. But if the cyst is more than 3 centimeters, if the main pancreatic duct is dilated, if the patient is symptomatic with pain or weight loss or jaundice, or there's intramural nodules, these patients require surgery.
Thank you, sir, for those very clear messages. So the incidentally detected pancreatic cysts should not be ignored. And whenever you have one of these features, please refer to them for further early treatment and investigation. So we'll come back to you, sir, later. And the next question is for Vikas. Obviously, H. pylori is the dominant risk factor for causation of gastric cancer. So the question is, Vikas, so any patient who is detected for H. pylori, should he be offered treatment? And if yes, what should be the initial treatment, given the fact that Dr. Govind mentioned that nearly 20% patients would have clarithromycin resistance? And what should be the first line treatment which we should give them? Should all patients with H. pylori be treated to prevent gastric cancer?
I think that's a very relevant question. So if we want to prevent the gastric cancer, there can be two scenarios. One is the patient with the gastric cancer who has undergone surgery and now is declared cured of the disease. So there is evidence that if these patients are treated with the H. pylori regime, there will be a reduction in the metachronous tumor. It will prevent the further cancer. And second scenario is patient is having a high risk factor during endoscopy for the gastric cancer. This is intestinal metaplasia or the gastric atrophy. So again, if we treat these patients, this can lead to reduction in the risk of gastric cancer. Otherwise, in a patient with dyspepsia, with the normal gastric histology, with inflammation, the H. pylori treatment will be given to treat the dyspepsia. But here, to prevent the gastric cancer, the NNT will be very high. So there is no recommendation in the community to treat the asymptomatic patients to prevent gastric cancer. And once you have detected the H. pylori, the most commonly used regime is the triple regime. It's a combination of PPI with the amoxicillin and the clarithromycin, and they should be given for the 14 days. If this regime fails, then we have other options. We can use the sequential therapy. We can use the levofloxacin-based triple therapy or the rifabutin-based triple therapy.
Because I'll come again to that question of H. pylori treatment, because it is very common. People now do serology for H. pylori detection, stool tests, and everybody is bothered that H. pylori is persisting. So once you have detected it, isn't it incumbent on us to treat it and ensure eradication? What do you say?
Yeah. So once we have done the endoscopy for the dyspepsia patient, so I think once you have found the H. pylori, we should be treating it. And once you have treated it, we have to confirm the cure also. And for that, we can do the stool H. pylori antigen. But one should wait for at least 6 weeks after stopping after completion of treatment. And one should again stop the PPI for 1 or 2 weeks before advising the stool antigen. And there is no need of repeating the endoscopy to confirm the eradication.
So the messages are very clear that you should not do endoscopy for all dyspepsias and do not check for H. pylori if it is not indicated, because if you detect it, then you are bound to treat it and then use your best possible drugs, ensure compliance, and also ensure eradication 3 months after completing the therapy. Is that right, Vikas?
Yeah, I agree, fully agree with you.
So in Japan, they have a very active surveillance program for gastric cancer. So how are we different from their population? Do we also need to have because upper GI endoscopy is such a easily available tool now, and with this narrowband imaging, chromoendoscopy, is there a role for defining a subset of people who should undergo surveillance to detect early gastric cancer?
Yeah, I think in Japan and China, condition is much different from India. The incidence of gastric cancer is much more common in China and Japan. Yes, in India, we have certain belts where the incidence of gastric cancer is high, like Leh Ladakh and the Northeast. The incidence is very high. In these patients, the threshold for doing the endoscopy should be very low. But at the community level, I don't think we need the screening endoscopy to detect the early gastric cancer. There are the few subgroups, I think, where it can be recommended. Like I mentioned, age more than 55, the dyspepsia, or less than 55. And one more thing we can add, the family relatives. When one member in the family has the gastric cancer, the siblings may be tested for the precursor lesions or the H. pylori, and they can be treated. But at community level, I think we don't need to screen for the early gastric cancer.
Thank you, Vikas. We'll come back again to you. So next question is for you, Ashish. Is there a role for insulin resistance in liver cancer?
Insulin resistance has a definite role for development of non-alcoholic fatty liver disease. In obesity, diabetes development, the insulin resistance is the key pathogenic mechanism. But directly its role in development of HCC is not proven, but there could be indirect role. But these patients who have non-alcoholic fatty liver disease, as they develop cirrhosis, and then as their cirrhosis progresses, then these patients definitely are a risk factor for development of HCC.
And another question is alcohol a risk factor for all GI cancers?
Alcohol is definitely a risk factor for liver cancer, and also for certain other cancers like even pancreatic cancers, Dr. Pramod has mentioned, gastric cancer. Definitely alcohol is risk factor for many of those, but liver cancer definitely alcohol is a high risk
Since
factor.
cirrhosis presents such an important predisposing cancer factor, and a triple phase CT is virtually diagnostic, so should all cirrhotics at baseline have a triple phase CT?
This cannot be a recommendation, but especially in tertiary care centers, if the patient is coming, definitely at baseline, the patient should undergo a CT scan. But at the community level, at periphery level, where the cirrhosis is diagnosed just based on ultrasound, then at least a recommendation cannot be made on doing a triple phase CT scan, because it's a very costly investigation. At least in Delhi, it costs around 15,000-20,000 rupees. So community level recommendation cannot be made, but if for person to person or case to case basis, if there are risk factors for if the patient can afford, or then definitely at baseline triple phase CT scan does make a sense.
But most of the gastroenterologists would do that.
Yeah,
Wouldn't
but
it?
most gastroenterologists are at usually tertiary care centers. So what I mentioned.
Picking up, if we want to pick up early cancers, why not?
Yeah, that's a good suggestion, but it only amounts that it is a costly investigation. And definitely, if the patient can afford, then at baseline it is best to do, and then we can follow it up later with ultrasound as well as AFP.
Thank you. Another question for Dr. Pramod Garg, sir. Is there any difference in risk factor for pancreatic cancer between type 1 and type 2 diabetes? Again, sir, diabetes keeps on coming back.
No, so both type 1 and type 2 diabetes might be risk factors. In type 2, obviously, diabetes for more than 5 or 6 years is important. And type 1, as you know, occurs very early. And some of these patients may also develop pancreatic cancer. In fact, a couple of studies also showed insulin by itself may be also, a risk factor for developing pancreatic cancer. So both are important.
Right, sir.
Sir, I have a question for you, Dr. Pramod.
Yeah,
So,
please.
many times we see that patients of acute pancreatitis, and then when we follow them up, some of them do develop chronic pancreatitis. At least they develop calcification or something. So is there a risk factor for them also developing chronic
Right. So I think what you're referring to is a situation where someone has acute pancreatitis, recovers from it, and you follow after 3 years, 5 years, they have features of chronicity. Now, one differentiation you need to make here is whether this patient has chronic pancreatitis or this patient has a disconnected pancreatic duct syndrome. So many times what happens that following necrotizing pancreatitis, there is necrosis of the gland. And if that necrosis involves the pancreatic duct, it leads to a stricture somewhere near the neck or proximal body of the pancreas. And the distal duct is then dilated. Now, this is often taken as an evidence of chronic pancreatitis, but this is not chronic pancreatitis. This is a consequence of acute necrotizing pancreatitis. But there are, yes, some patients who actually develop chronic pancreatitis with calcification as well. Now, these are the patients in whom there is subtle chronic ongoing pancreatic injury or inflammation, which is not manifest clinically as recurrent abdominal pain or recurrent inflammation. Now, these patients may have an underlying predisposition due to, say, for example, SPINK1 mutation or CFTR mutation. So they have very subtle ongoing injury, do not manifest clinically. These patients, again, are at risk of developing pancreatic cancer. In fact, there are a few epidemiological studies which show acute pancreatitis itself without converting into chronic pancreatitis is also a risk factor.
Yeah, Dr. Garg, yeah, sir, good evening. So sometime when we do the ultrasound for evaluation of pain, we may find solid lesion in the pancreas. And many of these can be the neuroendocrine tumors, maybe size less than 1 centimeter or 1 or 2 centimeter. So do all the NETs, they require surgery? Because we know pancreatic surgery has very high morbidity and definitely mortality also. So what's your take on that?
So, because again, it's a very important question. So as we mentioned about cystic lesions, if they're less than 3 centimeters, asymptomatic, do nothing, watch them. I think the situation in NET is somewhat different because NET may remain small and yet metastasize. That is possible. But at the same time, if NET is small, less than 2 centimeters in size, and asymptomatic. So NET can be both symptomatic and asymptomatic. Symptomatic, of course, insulinoma, gluconoma, you have to take care of that. But asymptomatic NET, whether or not to operate, is a difficult question. So generally speaking, what is done is that you have a small lesion, you make sure there are no other lesions, you do a Totonox scan and see there are no metastases, and depending on the location, patient's overall general condition, and patient's willingness, then you take a decision. So for example, you have a 1.5 centimeter lesion in the tail of pancreas in a 70-year-old man who is asymptomatic. I would say, wait, do nothing. You have a lady who coming with 2 centimeter lesion in the tail of pancreas. She is 45-year-old and there is a possibility it is NET, take it out, easy to take it out. You have a lesion in the head of pancreas, 1 centimeter lesion, treatment is Whipple's, I would say, hold on. So I think many factors have to be taken into consideration: the size of the lesion, the age of the patient, the location of the tumor, comorbid conditions, symptoms or not symptoms,
Sir,
and whether there are distant mets or not.
Sir, in elderly people, when we are talking of acute pancreatitis, so how common is malignancy as a cause of acute pancreatitis? And in elderly, especially putting the question other way around, if we do not find any obvious cause, alcohol, gallstone, how closely, how deeply should we work for malignancy as a cause?
Again, important point, and I did mention that unexplained acute pancreatitis in anybody above the age of 50 years, you have to go out and investigate for pancreatic cancer and do that repeatedly. That means you have a patient, 50 years, no other conditions, first time acute pancreatitis, patient recovers, you now investigate after recovery, 3 months down the line, 6 months down the line, and see if there are any subtle signs of pancreatic cancer. We have picked up cancers after 6 months also. So again, an important point for diagnosing pancreatic cancer in those who present with unexplained acute pancreatitis.
That is very important. So in elderly patients, you should not let these patients go if you do not have a definite etiological.
Absolutely,
diagnosis.
absolutely.
Right. So Vikas, you talked about H. pylori. So how common is obesity as a cause of gastric cancer? We all know proximal gastric cancers, and they behave differently from the H. pylori related cancers, and that is on rise. Obesity, again, there has been a question on obesity, pancreatic cancer, obesity, gastric cancer.
So Dr. Piyush, if we see the proximal gastric cancers, so the distal esophageal, G junction and the proximal gastric cancer, they are clubbed together in terms of management. They are classified by the Sievert classification. And it said that they may be related to the GRD also. And in this cancer, obesity is definitely a risk factor for the distal esophageal and the proximal cardiac cancer. It's a definite risk factor, especially if the patient has long-standing GRD, and patient who have GRD with the Barrett and obesity, they have multifold increased risk of these cancers.
Right. So that is very important. Dr. Anuj, we do not have any questions in the inbox, so we have been.
In fact, I had few of the questions in the inbox, and I got a very good answers from Dr. Pramod Garg and Vikas. So really, we had a very good session, and in fact, we are very poor as far as the cancer screening is concerned at our primary and secondary healthcare level. That's why all burden of the cancer management comes on the tertiary care. And it is really much more as well as it becomes too late when patient reaches to the tertiary care. If we can really make this thing to understand in our physician that cancer screening and cancer, how to suspect and when to suspect these cancers at the primary healthcare level when the patient comes to them, probably we can reduce the occurrence of the cancer in all the segments what you talked about. As very rightly Dr. Prabodh said that sometimes therapeutic reasons are also there which can give rise to the cancer in certain patients. Like Vikas Singla has also mentioned about the therapeutic reasons, as well as sometimes we don't do the therapy. Sometimes H. pylori is not tested and it's ignored by many of the physicians up to the very late level. And because of what it becomes too late to diagnose the GI cancer or gastric cancer especially. And really very rightly said by Ashish that liver cancer, I think liver cancer is very commonly increasing in our population. Earlier it was only seen in those patients, those who are alcoholic. But now we can see a lot of non-alcoholic patients are also developing the liver cancer in one way or another way. So this thing is spreading like anything, but still our focus is not on the early screening. Can we really do something? This question from all of you experts. Can we really do something to tell our primary healthcare physicians, those who are working at the patient when he goes first to them, to do anything to avoid pancreatic cancer, to avoid CA stomach, to avoid the liver cancer? Can we really tell them anything like that?
So, Anuj, I think you are asking a very generic question. So what you're referring to is at the population level, what are the measures that one can take to decrease cancer-related mortality? And that means prevention of cancers. And I think individually, if you look at different types of cancers, there are only a few where a population level surveillance has been shown to decrease mortality. Colon cancer, I think, is the best example. Even for breast cancer, we are still not sure if a mass level, population level screening is going to help much. So individually, for example, in Japan, gastric cancer is very common. They have a population level surveillance. Anybody comes in, they will do endoscopy and look for an early gastric cancer. I think such a strategy can only be applicable, be cost effective, only when your incidence of that particular cancer is very high in that population. Going merely by the symptoms of the patient or certain risk factors is not adequate to justify screening at the population level. What I think we have discussed today is some specific instances where such a strategy would be useful. And I think what Ashish mentioned, a patient with known cirrhosis, where we know the risk is high and ultrasound of the abdomen is a very widely available and a cost-effective investigation, should be done periodically. So this is absolutely justified. This is what I think we should be telling the audience, the general population, the general physicians. But for example, in pancreatic cancer, we don't have a strategy as of date. But what we discussed, and Piyush mentioned, that any elderly person coming with abdominal pain, weight loss, we shouldn't just be giving, PPIs and a painkiller. I mean, these are the patients who require further investigations. Anybody who coming with elderly person with dyspepsia, we just can't say, okay, take pantoprazole and be happy with it. Because very clearly showed you early gastric cancers coming in. And it's not that it doesn't occur in India. Northeastern region, there is very high incidence. So one has to be careful But overall population level screening strategy, I think we need more data and more outcome data actually.
I think, sir, we should encourage the healthy lifestyle.
Absolutely.
We should have more intake of the fiber, fruit, vegetables. That should be encouraged, and obesity should be avoided. If you take care of that, I think many of the cancer, they can be prevented.
In this
And then
connection, Vikas, I'm interrupting you. Sorry for that. Many people also link the cancers with the insecticides as well as the pesticides what we use in our food and some coloring agents what we use in our food. So we should also make the people aware about that. How can it make a lot of impact on occurrence of the cancer?
yes, definitely.
Ashish.
Yeah, especially pesticides. There have been certain like trans fat is there, which can increase certain kind of cancers, and especially certain pesticides and insecticides do increase cancer. That is why in many of these countries they are banned. So increasing the awareness among general population is one thing which must be emphasized. And the second thing which Dr. Vikas Singla mentioned, that healthy lifestyle would prevent all types of cancer. If you avoid alcohol, if you avoid tobacco, you will prevent your head neck cancer. If you avoid alcohol, you will avoid liver cancer. And if you are of healthy weight, if you are not obese, then many of these cancers can be prevented. So healthy lifestyle and having lots of fibers and vegetables, that would definitely, and avoiding high fat diet, avoiding high salt intake, for example, in gastric cancers, or that kind of diet should be avoided. So
these are the suggestions what we can give to our population. But
yeah.
If we have to give some suggestions to our general physicians, especially those who are working at the primary healthcare level, we do not have any consensus at this time. How should they detect the early stages of the cancer? How should they try a prevention? And who are the candidates whom they should think about that it may be more predominant or it may be more prevalent, and these set of the population needs some specific steps to prevent these kinds of the cancer. Is there any such kind of the consensus is there? Would like to listen from any of you experts or all of you.
Dr. Piyush and Dr. Vikas, I think everyone mentioned that if an elderly patient comes with a new onset symptoms, like new onset dyspepsia, elderly patient, then these general physicians should be aware of these alarm symptoms, like weight loss is there, new dyspepsia is there, or certain, for example, elderly patient pancreatitis has occurred. So these patients should be thoroughly investigated. For day-to-day routine average patients, like a young patient, if they come with new onset dyspepsia, it's okay to give them PPI. But in elderly patients who have come with alarm symptoms, there's weight loss, there's been history of GI bleed, then definitely there's unexplained anemia going on, then definitely these awareness among the physician that we should not ignore these symptoms among the patients, that should be the take.
Dyspepsia has been very common in our youngsters population. Now teenagers are coming up with a lot of dyspepsia problem because of the late night eating, partying, alcohol, smoking, everything they are doing. And this has been much more from our times.
So dyspepsia with alarm features and dyspepsia without alarm features is a different thing. So dyspepsia along with weight loss, dyspepsia with GI bleeding, and then these definitely require a new onset dyspepsia. Dyspepsia which has going on for years is different thing, but which has now occurred recently within 3-4 months, that definitely requires investigation. Dr. Piyush?
Anemia is one very important point which Ashish raised. So in any elderly male patient, if you have anemia, don't stop at just giving iron, just getting the B12 levels and all those things. Any patient with anemia needs a good investigation. You will pick a good chunk of gastric cancer, you will pick a good number of colon cancers in all these patients. So for primary care physicians, or for that matter, any person who is looking after clinical work, proper history is very important. Triaging these patients is very important. You need to know what Ashish mentioned as the red flag signs. This holds true for all. So you have to, in absence of any broad surveillance tools which we have, cost-effective surveillance tools we have to really narrow down on these patients who need more closer look. Elderly patients, anemia, weight loss. So this is for the general physicians to understand and sensitize them to not ignore these patients and refer them for more thorough investigations in this setting. So this is at the physician level, and at the population level, everybody has mentioned about the role of adopting a healthy lifestyle, smoking, alcohol, obesity. I mean, these three things, if can be controlled to a large extent, many of these modifiable risk factors for many cancers would be controlled.
Thank you, Dr. Piyush and Dr. Ashish, for very nicely moderating the session, and all the speakers, Dr. Pramod Garg, Dr. Vikas Singla, Dr. Ashish, for giving us very good presentation, very good ideas about how to prevent and how to find or detect or identify the patients with the cancer, various kinds of the cancer. In fact, in the physicians group, it is very little talked topic. Cancer is not so much talked as it is being talked in the super specialist or subspecialist groups. So it was really our endeavor from the American College of Physicians that India chapter should start such kind of the awareness, not only for the GI cancer, but all kinds of the cancers we try to do in this month of February, which has started from the World Cancer Day from the 4th of February. And I'm very much grateful of Dr. Ashish, who has thought about the organizing this kind of the update on gastrointestinal cancer for the physicians and for the primary and secondary healthcare level. And he could be able to coordinate such a high level of the speakers like Dr. Pramod Garg, like Dr. Piyush Ranjan, Vikas Singla, and Govind Makharia, and Ashish is himself, although we have been postgraduate mate in KGMC, but really here I could see him in a very different level, which has been quite appreciable. With this, I thanks to all of you who has done the wonderful presentations to us. And I also thanks to all the attendees who attended this platform as well as put up their questions. I'm happy that today has got a lot more questions on the cancers as we could see in the earlier session. So definitely your talks and your moderation was quite stimulating for the attendees. And this is the success of the program. With this, I congratulate our moderators and chairperson as well as all the speakers. Thank you very much. And this is the completion of this cancer awareness series by the ACP India chapter. In the next month, we shall be starting some other topic, maybe related to the kidney disease or related to the obesity. In the next month, we shall be talking about that. With this, I take farewell from all of you. Thank you very much for being with us. Looking for the next session someday. Thank you.
Thank you very much.
Good night. Yeah.
Bye-bye.